USMLE style question focused on biventricular pacemaker lead placement in the left ventricle. USMLE question on biventricular pacemaker lead placement. A 72-year-old man with a history of dilated cardiomyopathy, chronic heart failure with reduced ejection fraction, EF 30%, and left bundle branch block presents for biventricular pacemaker implantation. During the procedure, the left ventricular lead is advanced through the coronary sinus to optimize resynchronization therapy. Question: in a successful biventricular pacemaker implantation, where is the left ventricular lead most commonly positioned? Option A, the right atrium. Option B, the apex of the left ventricle. Option C, the lateral or posterolateral wall of the left ventricle. Option D, the right ventricular outflow tract. Option E, the interventricular septum. The correct answer is option C, the lateral or posterolateral wall of the left ventricle. Explanation: biventricular pacemaker implantation, cardiac resynchronization therapy, is used to improve the coordination of ventricular contraction in patients with heart failure and dysynchrony, often due to a left bundle branch block. The left ventricular lead is inserted through the coronary sinus into one of its tributaries, typically a vein that drains the lateral or posterolateral wall of the left ventricle. This location provides optimal electrical activation of the left ventricle, correcting the dyssynchrony. Placement at the apex of the left ventricle is avoided due to the risk of thromboembolism or misplacement through systemic circulation. The right atrium and right ventricular outflow tract are not targets for left ventricular pacing. The interventricular septum may be targeted in specialized pacing techniques, but it is not standard for left ventricular lead placement in CRT. This procedure highlights the importance of coronary venous anatomy and accurate lead placement for effective therapy. Thank you for